One second.
We're going to hide Dr. Lever while he takes that phone call. We are live at about 2 minutes after 12 on the East Coast on April 3rd, 2020. Okay, Dr. Lever's phone call is off, so we're going to bring it back on screen with us. Today, we're going to start with a brief COVID update on one particular issue, and then we're going to do a little dive into history and a conversation with Dr. Lever, and hopefully you can all join us and ask your questions. Number one, I want to talk a little bit about a change that occurred yesterday in Manhattan, in New York, and the 5 boroughs regarding EMS response to cardiac arrest. Now, this is a matter that is near and dear to our hearts, pun intended, because patients with HCM are, in some cases, at an elevated risk of cardiac arrest, regardless of the COVID situation. What has happened in New York is they have directed EMS, if they are responding to cardiac arrest, to provide care in the field, which will include paramedic care. They will use medications. They will use defibrillation. But if they are not able to get a heartbeat back and it's sustained, they are going to pronounce people dead at home and leave them there and not bring them to the emergency room. This is one of those sobering moments in this epidemic or pandemic that we have to stop and say, even if we're not affected by COVID, what do we need to do as patients with cardiac disease to protect ourselves? And you all have heard me talk in the past about sudden cardiac arrest risk assessment. And those of you who are at high risk, you know you need implantable defibrillators. Those who are at intermittent risk or low risk doesn't mean no risk. And given the current standing of EMS workers being challenged, they're sick as well, the response times are slower, this may be a prudent time for patients with HCM to consider bringing in an external defibrillator into the home. It does in no way replace an implantable defibrillator for those of you who are at high risk. But some of you might be at intermediate risk. You might be in an area where response time from EMS is slower. And we know that if you defibrillate early, your chance of survival is very high. If you wait a long time, meaning, anything after every minute, you lose 10% chance of getting yourself back or getting back that person. So after 10 minutes, chance of survival is pretty small. EMS response times are longer now because there's more of a need. So it might be prudent to consider bringing an AED into the home. And in the next couple of days, I'm collecting some information and I'm working with some of our partners to come up with some more cost-effective ways for you to do that. And I will be giving a complete presentation, hopefully before Monday or Tuesday, on how to access an AED, how to work with your insurance carrier, how much they cost. And we're trying to find the best deals out there to help get AEDs into your home if you feel that you need one at this time. I have spoken to some manufacturers, and those manufacturers say that they have availability and they are shipping out. So there are certain devices that are home devices that all you need to do is order it. You don't need a script, but it's going to cost you out of pocket. You might be able to use your health savings account. So we're going to talk all about that in a future broadcast, but I wanted to bring it up today because it is an important issue. And those of you who have watched the New York media, it's a little scary to see it. But I don't want you to think just because you call in a cardiac arrest, they're not going to come and they're not going to try to help your loved one. They are. But if they can't get a heartbeat back, they're not bringing them into the hospital for advanced life support. So let's give everybody the opportunity to survive these events and make sure that you're protected and you have a plan in place. So Dr. Lever, I've given that little update. Do you agree with my comments here?
I think when we have a problem where we don't know which way things are going, it's better to be cautious than not. So
I couldn't agree more. Okay, so I am having a little bit of an issue with my question feed popping in here. So I'm just going to log in onto my computer or on my phone here. So give me 1 second to get that up so we can get the comments. I might not be able to bring them on screen if they're being difficult. I might have to read them in. Oops, wrong page. Sorry, 1 second. Nope, wrong page again. We have too many pages. We have so many pages. Over here. Okay. So I thought it would be fun if Dr. Lever and I would do a little history lesson for you all, because how did the girl from Jersey find the doctor at the Cleveland Clinic who handles HCM patients. So I'm not going to go into the entire HCMA history right now, but I am going to talk a little bit about how, there we go. We have people now coming in. There we go. And I can see this. So if somebody just wants to pop a message up and just say hello or something, that might start my feed going with the questions. There's a little delay on that technology right now. So anyway, back in 1996, we started the HCMA. Actually, my incorporation date is February 1996. So we actually started the work in the fall of 1995. And I was going around looking for, thank you, Michelle, looking for physicians who specialized in HCM. So I looked up documents and articles that were published, and Dr. Lever's name came up on a few. So I reached out to him and said, hey, I'm starting this patient support group. Are you interested in assisting us? Because I understand you do a lot of work in HCM. In November of that year, 1996, the American Heart Association had its scientific session in New Orleans. And I thought, well, I'll just ask a couple doctors to dinner. So, Harry, why don't you tell us what you remember about this time period?
Well, I flew out of Cleveland on a Saturday, and I was on probably the last flight out that day in the afternoon because we had a bad snowstorm. And so it was lucky that I even got to New Orleans. And I can remember calling my wife each day for the next 3 or 4 days. And I said, how's the weather? Well, it's still snowing, and it's still snowing. And I mean, we must have had, I don't know, a foot or foot and a half of snow by the time I got back. So it was a bad one, but I was able to get there. And I can remember coming into the exhibit hall, and Lisa was there, and had her posters or whatever up on the wall, and we started talking. And it's that it just developed from there. And it was I can remember she arranged this dinner at some bar out in the Garden District of New Orleans, out at the end of the streetcar tracks. And I mean I'd never been out there, and I've been to New Orleans a couple of times, but I didn't know really where I was going. And taxi driver was taking, I kept going and going and going, and finally we arrived at this place, and it was at the end of the track, as I remember, where the car actually made the turn to head back. The streetcar turned back, and what the heck is going on here? So we went inside, and there she was. So it was and I remember Marty. We didn't call a taxi to go back, but Marty Marin drove me back. He was at the meeting, and he drove me back to my hotel. So I felt a little better about that. But it was, but at that time, after meeting her, our patient referrals dramatically increased, and we were doing about 25 myectomies a year. And I think within a year or so, we were up to 60. And it just grew from there. And, and Lisa has become, or had for the longest time now, has been the single biggest referrer of patients to us. And, it's, it's been a good relationship that she's really helped a lot of people. And I tell people that one person that's done more for patients with hypertrophic cardiomyopathy than her. And it's really true. She's really been out there helping people. And so we've had a very good relationship all these years, and we're continuing.
And that's the way it started. So I was thinking back when we started talking about this earlier as to who was at that first dinner. It was Barry Marin, Bill McKenna, you, I think Mark Sherrod was there, Christine Seidman. Marty was a student. He was an undergrad at Tulane. And the only reason he was there was because the meeting happened to be in New Orleans. And I said to Barry, as I was trying to plan something to start the medical professionals talking in a more organized fashion, I'm like, I don't know where to go. He goes, oh, my son goes to school there. He can help us find some place, which is why we ended up in this remote, it wasn't a bar. It was a small restaurant, Frank's, I think it was called. And it was in the Garden District near the Tulane campus. And Marty was there as a student, and there was another patient there, and his name was Chuck Morrell. And Chuck was a filmmaker from LA who had a heart transplant due to HCM and was a really good friend in the early days. And his daughter now runs an organization doing heart screenings out in California. So it's funny how far we've come, and some of the names are still the same, and there's a lot lot more new names involved as well. So that's where it all began. And yeah, I think you were doing 23 myectomies the year that I asked you in the beginning. So like 95-ish, 96. And last year you guys did what, 220, 230?
I don't have the exact number right now, but it was a bit over 200.
Yeah. So you and Mayo are right up there. Cleveland and Mayo are up there in the numbers in that 200 plus range, and making you guys the two top producers in terms of numbers of myectomies in the United States. So that's how it all started. And, it's keeps going from there. And I want everybody to make sure that they look over Dr. Liver's shoulder to see Doc sitting behind him in the chair. I'm like, leave him there. It's adorable. So yes, we're all working from home, and we're all getting to see everybody's world in a whole different way, which I think is kind of interesting. So I welcome your questions here today. I'm going to start off with some generalized questions about the difference between an HCM Center of Excellence and community-based cardiology for the care of HCM. So Harry, let's start with the question of, when a patient's coming to you from a community base, how often, or maybe that's not the right way to word it, but when you see them originally, how much work needs to be done to assess where they really are with their HCM, and how much rework needs to be done on average?
It sort of depends on where the patient's coming from, but sometimes I'm just presented with an echo. Sometimes I don't have anything. Sometimes the patient's had an echo and they don't send it. So most what we've been doing with most of the patients that we see is, if we do a resting echo, we do a stress echo, and we do an MRI scan. And we're finding the MRI scans are very helpful in patients to look, particularly with the somewhat thicker septums. Although I think when we look at HCM patients in general, probably the average septal thickness is about 20 millimeters. But and they're above and below that, but about 20. But when we see really thick hearts, we really rely on the MRI to see how much scar tissue is there, because we've recognized that scarring is an indicator that puts them at increased risk and would, push us maybe to need a defibrillator. And I can remember a few patients that we put defibrillators in solely based on the scar burden, and within a year, they needed it. They needed that defibrillator. So that's been a very important part of the workup. We're having some trouble now trying to get these done because insurance companies are having a lot of pushback. They don't really want us to be doing this kind of stuff, but we have to fight them, and we usually win. We do the stress echo to see what the exercise tolerance is, and that's important because some people come to me telling me that, they feel fine, and we put them on the treadmill, they can't do much of anything. Other people say they feel bad, and we put them on a treadmill and they do well. So the treadmill helps us decide in the obstructed patients, whether resting or provocable, whether they really need to have surgery based on what their exercise tolerance is. So then we monitor the patients. Early on, we were doing 48-hour Holter monitors, and now we might start out with a 48-hour Holter monitor. But if we have any question about arrhythmias, we can now monitor them for up to a month at a time. So that's very helpful. So that's kind of what we do when we see patients for the first time. As far as following patients, we do a yearly echo, and then the MRI scans. We're starting to do them now every 3 to 4 years. Maybe we're not doing them every year. We want to get some idea of if the scar has progressed. In some people it does, sometimes it does, and other people remain absolutely stable. But we think that's important, and we're going to have to learn over the years, really, to get an idea of, are there any indicators for why some people progress and other people don't. But we're just learning that.
So if somebody's coming in fresh to Cleveland Clinic, and this extrapolates out to many other centers as well who have a high volume care model for HCM, but when they're going to come in, so you're going to assess the anatomy. So you're going to look at the heart with imaging, MRI, echo. In some cases, there might be a TEE with transesophageal echo. And in some cases, you may use a contrast agent so you can really identify the anatomy. And then there's the question of how do you assess obstruction and heart function, and how do you assess risk of sudden death? They're two separate pathways. Could you explain the difference between
Well,
look at each?
I'm not sure that we've seen tremendous correlation between outflow tract obstruction and the risk of sudden death. It's hard sometimes. We worry, of course, when the gradient is high, but I think that we're and one comment first about the transesophageal echo, because I didn't mention it. Most of the time we don't need it, but we've come across a group of patients who have minimal septal hypertrophy and have a lot of outflow tract obstruction at rest or with provocation. And, we need to see exactly what the mechanism for that outflow tract obstruction and mitral regurgitation is. And the transesophageal echo, particularly when we're dealing with what looks like elongated mitral leaflets, helps us better define that anatomy and look at the papillary muscles also. I can remember a patient a few years ago we operated on who had an episode of VT. He had passed out. He had a defibrillator by the time he came to see me, but he had a 14 millimeter septum. He had a papillary muscle that was directly attached or near directly attached with short cords to the anterior leaflet of the mitral valve, and he had prolapse of the posterior leaflet. So when he was operated on, that extra papillary muscle was removed, the prolapse was repaired, and we never did a myectomy on it. He didn't need a myectomy. But we learned a lot when we did that transesophageal echo. So there are times when we need to do the transesophageal echo to better define the anatomy that sometimes we don't even see as well on MRI scans. So it's that's why the TE can be very helpful. And we're certainly not doing them on everybody. We just do them when we think they're needed.
So I'm going to pause there for a second, because you brought up an excellent point that I have tried to get across, and sometimes I do well and sometimes I probably don't. Anatomy matters.
Right.
Hypertrophy is a part of hypertrophic cardiomyopathy.
Right.
But these abnormal papillary muscles, these abnormal mitral valve leaflets, can you just explain a little bit more to people who may not really understand what is a papillary muscle?
Well, papillary muscle is a structure that is attached to the lateral or medial wall, or most people have two papillary muscles. Some people have three papillary muscles. Some people have a papillary muscle that is located in the tip of the heart. Most of the time they're on the lateral and medial walls, both sides of the heart in the left ventricle. But some people have a papillary muscle that's right in what we call the apex, or the tip of the heart. And when you have that, it tends to move that mitral valve closer to the septum, and because it's moved closer to the septum, you can get outflow tract obstruction. So there have been some patients where we've had to do plastic surgery on the papillary muscles and maybe move two together and sew them together and put them together so that one is better supported. Some papillary muscles are thin and small and weak and don't anchor the mitral valve very well. So there's a whole variety of anatomy that we can see in the papillary muscles that we learned about a lot at the clinic because of the fact that early on in the early 1980s, Dr. Cosgrove learned how to repair mitral valves. So we saw lots of anatomic variations in papillary muscles and mitral leaflets in dealing with mitral valve prolapse, and we were able to take that recognized after a time that a lot of patients with hypertrophic cardiomyopathy had that different varieties of anatomy. And when I went to medical school, we were always taught, well, they're two papillary muscles. And there was a classic paper that was describing that in the Annals of Internal Medicine in 1972. It was a classic article, but things were clearly different now. And so we've come to recognize the anatomy is highly variable.
I'm trying to play with the screen here a little bit so I can show pictures of what HCM looks like. I'm going to hide some screens for a minute so I can so I can make this look right. Give me 1 second. 2, 1, 2, and that way we can make this one larger. Okay, so it's not the best image possible, but it's really probably not going to work too well. But for anybody who's familiar with our awareness poster of what HCM is, you can go to the HCMA website, pull this up, and you can kind of look at the anatomy as Dr. Lever was explaining it. And you can replay this back and blow up these pictures, and you can kind of see where the papillary muscles are. They're these little apparatus down here, or sometimes they're, as he explained, they're placed wrong. And because they're placed wrong, that might create some symptoms. And it's important to know the difference between whether you have outflow tract obstruction, mid-cavity obstruction, apical presentation, accessory papillary muscles. All of these features of the HCM heart play a role in how somebody feels and what can be done to improve their quality of life. So having said that.
And actually, you mentioned the mid-cavitary obstruction. There was a time early on when we wouldn't have even considered operating on somebody with mid-cavitary obstruction, and they didn't have SAM, but they'd had mid-cavitary obstruction. And we've done a number of those because the septum is thick and those papillary muscles come and they hit in the mid portion of the ventricle and cause trouble. And we've successfully operated on them. So the anatomy, watching the anatomy carefully and what we've learned has allowed us to operate on more patients and make them feel better. Because those with mid-cavitary obstruction, there never was, we never thought about operating on them. And the other group with very severe apical hypertrophy, sometimes the ventricle is so small, we've operated on a very small number of them just to give them more cavity size. They don't really have obstruction, but the cavity is so small, we just carve out some muscle to give them more room so they have better cardiac output. So our indications have gotten a little bit more.
Okay, so sorry, I got a text message here from somebody. We have some questions. I'm not necessarily going to hit them in order because they keep scrolling by. So I will eventually try to get to all of them. So hang with me. And I'm going to go backwards now. So Michelle said that she had papillary realignment at Cleveland Clinic, and Dr. Smitter abandoned them and tried to keep them more parallel. So that's an interesting point of view. Kathy has a question. Is apical aneurysm associated with an apical papillary muscle?
No, it's more associated. Well, it's associated with apical apical hypertrophy. And it's interesting. Some of these patients, when we look at what looks like apical hypertrophy, it is actually a papillary. Part of it is the papillary muscle that's put out into the apex. So if you could, it's some of that. What looks like hypertrophy of the lateral wall or the septum is actually the papillary muscle.
Okay, so Gretchen has a question. Do you take into account the age of a patient when recommending an MRI? And I know the backstory here. So is there a difference between what you would do in a pediatric, and I know you're an adult cardiologist, but pediatric, adolescent, and through stable young adult? When do you do an MRI, and how often do you repeat it?
Well, I think we're particularly want to do the MRI in patients who have very thick hearts to see how much scar there is. That's very important. I can remember a patient with non-obstructive HCM who we put her on a treadmill and we could not get a gradient. But when we did her MRI scan, she was 18 years old at the time. She had very severe scar. And as a matter of fact, the ejection fraction was a little bit reduced, but the scar was very severe, and she dropped her blood pressure during the stress test. And we decided she should have a defibrillator. And within about 10 days to 2 weeks of that defibrillator going in, she was at school and had a cardiac arrest, and the thing saved her. So it's, I can remember the mom calling me from the ambulance that had resuscitated her in school, and they were on the way to the hospital, and it saved her life.
So I'm going to dig a little bit deeper into Gretchen's question. And I'm going to ask some questions that are probably floating around her mind right now. When we're dealing with MRI and late gadolinium enhancement, What are the most important features to you as an HCM physician? Is it the placement of the scar, or is it the degree of the scar?
It's the amount of the amount of the scar. We frequently see a little bit of scarring in what we call the insertion points of the right ventricle, and that's not that significant. But when we see scarring that's more than 15% of the ventricle, we worry about that. So it's and if there's no scar, we're not running in to put in defibrillators. And I must tell you, one of the problems I have seen over the years is that too many people put in defibrillators in patients who may not need them. And I've seen numbers of patients who are dizzy or even pass out, and they had the defibrillator, never went off. So it's the outflow tract obstruction that makes them pass out. So we try to risk stratify them as best we can, and not putting defibrillators in everybody, because they have their own problems. We've had over the years problems with pacemaker wire or defibrillator wires that crack and break, and now we have a defibrillator that you can put in that wire just lays on the outside of the heart, so you don't have the problem of motion in the heart, so they may last a little longer, but they're bigger, they go under the arm, and they can be somewhat uncomfortable. So none of them is perfect, but so we just try to put them in when we think somebody really needs it.
So, okay, we have, I'm going to go through here a little bit more. Oh boy, I wish there was an easier way for me to scroll through all of your good questions here, so it's a little hard. Okay, Susan, that's great. Anthony, wondering if there's a need for routine follow-up heart catheterization done prior to the myectomy. Should a catheter be done again if there's symptoms?
We always do a coronary angiogram when we're going to the operating room. We always want to look to make sure that there's no coronary artery disease, and younger people, we want to make sure there are no abnormal arteries or something. We don't want any surprises when we go to the operating room. And I would say, looking over the years, the incidence of coronary artery disease in hypertrophic cardiomyopathy patients is not very high. I don't think it's more than 20 to 25%. Of course, it goes up with age, but it's not that high. And usually the arteries in hypertrophic cardiomyopathy patients are large, and they tend not to get as much coronary artery disease. But we don't want to go to the operating room, open somebody's chest without knowing that anatomy.
So I'm going to go backwards here a little bit. So why a cardiac cath in HCM? And I'll preface it by saying sometimes when patients are contacting the HCMA for the first time and they've not been to a center of excellence yet, and they've had 3 and 4 and 5 cardiac caths, one, can you speak to maybe why they're having so many caths ahead of getting to a center of excellence? And then what is the role of a cardiac cath? What are you looking for? And when would you consider doing it in a non-obstructed patient?
We're basically doing left heart cath. We're just looking at the coronary arteries. And, I don't know. I mean, if they're, and as a matter of fact, if they're relatively young and they've had a coronary angiogram within 2 years or so of me seeing them, we're not doing it before we operate. Just, because they're young and the chances of developing in a couple of years isn't very great. But we're tending to do it in people who have never had that coronary angiogram. And it's not clear to me why more than 1 or 2 coronary angiograms are done on people. But on the reverse, I had a patient about 2 years ago who came to see me. By the time he was having all kind of chest pain, by the time I had seen him, he had 10 stents in his heart. And they didn't recognize that he had hypertrophic cardiomyopathy. And so and he was feeling absolutely miserable, and we ended up taking him to the operating room. He needed a couple of bypasses at that point, but we did a septal myectomy, and he's done somewhat better. But it was very difficult because, psychologically, he had felt so bad for so long that the recovery was somewhat difficult, although he's much better than he was. I'll never forget that. And I've seen a number of patients who have had stents put in before the before a myectomy was done, and that's clearly wrong. I think if you have hypertrophic cardiomyopathy and you're having chest pain and you have coronary artery disease, you try not to put that stent in, and you do, because you're going to operate on the heart anyhow, and you do a bypass operation and the myectomy at the same time.
Okay, so the left heart cath is used to evaluate for coronary artery disease that might accompany the HCM.
Right.
And you see that in about 20-25% of patients who have both coronary artery disease and HCM. And the purpose of doing the cardiac cath ahead of a myectomy is so that when you go in and do the myectomy, if you need to address any blockage, you can do it all at one time. You don't have to go back into that chest.
Exactly.
Okay.
Right.
Now, that being said, when do you consider a right heart cath, and what's the difference between a right and left heart cath?
We do right heart caths when we're suspecting that there's pulmonary hypertension or very severe mitral regurgitation, and we want to see if there is pulmonary hypertension. And, fortunately, we don't have to do it that often, although over the years we've seen some patients with very severe pulmonary hypertension. And, when pulmonary artery pressure gets into the 80 or 90 systolic, that increases the risk of surgery. And it's not to say we won't do it, but we like to be prepared, so we're not surprised when we come off a bypass and see that they're having a little bit of a tough time. So we know why it's happening, and we deal with it. But that's sort of when we do it. But the run-of-the-mill patient, we're not doing right heart caths on most of them.
Then there's the group like me who go off to transplant, and you have to do the right heart caths on a regular basis to check on pressures.
Right.
We're only 4 or 5% of the population, and then you get like this nice grouping of scars over time, but that's for the transplant group. So left heart caths are for the majority of HCM. Right heart caths tend to be for end-stage disease and checking for hypertension or pulmonary hypertension and end-stage numbers. Okay, lots of questions. I'm going to go back to some MRI stuff for a second. So are there any other contrast agents that can be used other than gadolinium if someone has an allergy?
No, not usually. No.
Okay. So Gretchen, I am going to be very delicate here with how we address your questions. And this is, we get personal here sometimes, and we're having to deal with topics that are very sensitive. And in this particular case, we're dealing with somebody who's had a loss in the family. So Gretchen is asking if you would reconsider your position into assessing a spot of scar in a particular region over total scar. And I'm going to ask you to address the data. What do we know about scar burden in HCM?
Well,
and is there a particular hotspot area, or is that not an accurate thought?
It's more the amount of scar that's spread through the heart. And quantitatively, it looks like when Marty Marin's group, they looked at when it gets to be about 15% or more, it looks like the risk is increased. But it's not like just one spot that we worry about. I mean, we tend to look at the whole scar burden.
So in a particular case, if there were a focal point in a particular region of the heart, papillary muscle insertion point, up in the top of the ventricle, in the septum, these focal point scars have not historically shown to be any higher risk than sporadic patchy scarring, as long as the percentage is under 15%.
That's right. That's pretty much the way we've looked at it.
We're still learning. We still may learn more. We have been very good at identifying high-risk populations, specifically using MRI, but the low risk never means no risk. Is that true?
Right.
And that becomes a problem. Okay, so let me jump into a couple COVID questions. I know there was one up top. I have to keep going back between my glasses and not. Okay, so Gretchen, I'm going to give you a little bit more airtime here. What is the death rate among HCMers with COVID? The AACC guidelines from February was talking about cardiovascular disease risk associated with COVID. To date, I'm aware of maybe 2 deaths worldwide with HCM. Both of them were elderly people who had other comorbidities. So we don't have a great big repository of data of COVID HCM. But can you address what the cardiovascular risks were that ACC was talking about early on?
Well, to be honest with you, I hadn't seen that, but the fact is that just because you have heart disease and the ventricle's stiff, or you have outflow tract obstruction, and then you get trouble with your lungs, you're going to be in more trouble than the average guy who doesn't have that. So I think we're so early into this problem that we don't have really good data. But we've been telling people that have hypertrophic cardiomyopathy, stay home. Don't go out of the house, and stay away from people. And again, it's not based on any hard data, but we know that lots of people are getting, or a fair number of people are getting sick, and they get really bad looking chest x-rays. And you can just imagine if you had hypertrophic cardiomyopathy on top of that, you could really get into trouble.
So somebody else brought up the use of hydrochloroquine, anti-malaria drug. So I have to say I have a real big issue on this one. I've been really following the data very closely here. And while there were some cases where it appeared to be beneficial, there's just as many cases where it didn't seem to be beneficial at all. And that's why clinical trials are really, really important. And we need to get better trial data before we know.
We hardly have anything, and anything that's out there is so preliminary that we don't know. But it is something that can be tried if the patient's in terrible trouble. I don't think, as a matter of fact, I've got to call somebody this afternoon. They're asking me about azithromycin and hydroxychloroquine. And one of the things you've got to be careful with patients is, what does their resting electrocardiogram look like? Because the hydroxychloroquine can prolong the QT interval, and that could predispose you to VT. So we've got to watch. And I think if it gets to the point that it looks like it works, if it does, then we've got to make sure we got an EKG on somebody. And certainly, that's one of the downsides. We just have to see. We just don't know yet.
So I addressed this earlier in the week, or maybe last week. If you think you have access to this medication, this malaria medication, and a Z-Pak, which is basically what some people are touting is some type of a panacea that we have no data on yet, that it works or not.
Right.
Do not take it at home. If you have HCM, you need to be supervised, because it elongates the QT interval. You could be placing yourself at risk for sudden cardiac arrest.
Exactly.
Do not do this at home.
Nope.
Do not take a prescription from your GP and say, I'm just going to pop it at home, because you may find out that the downstream consequences are quite severe.
Right. Exactly.
Okay. So Kathy had a question about apical HCM again, and that papillary muscle. So a center of excellence can tell you, yes, if you have apical presentation or the papillary muscle is in the apex, which I don't know that I've ever seen a papillary muscle in the apex.
We've had a fair number of them. We've seen a fair number of them. Yeah.
And if somebody were to have that anatomy, I'm trying to think of a few of them. Yeah, maybe. Yeah. Okay. Yeah.
Because it tends to push the papillary, when it's in the apex, it tends to push that papillary muscle closer to the septum.
Yeah, and then but you would
now it all depends on, let's say if the septum is very thick and the mitral valve is anteriorly displaced. If the septum is thick enough, sometimes all you have to do is just remove the septum, and that'll take, the distance then will be so great away from the septum that you don't have to worry about the position of the papillary muscle. It's just that when you're dealing with a septum that's not so thick, and do you have to move the papillary muscle a little bit? Just depends. Each case, we got to look at each case and the anatomy very carefully.
Okay. So Meg is asking for a friend. Are there any indicators, or particular populations of patients post-surgery that indicates electrical issues not immediately after surgery, like months later? I'm assuming you're asking about heart block. So are there heart block issues that can be produced post-myectomy? And are there any additional arrhythmia burdens that can be produced post-myectomy?
Well, our overall incidence of complete heart block after myectomy is about 3%. And if you start out before you go to the operating room and you have a right bundle branch block, it's about almost 100% chance you're going to get a permanent pacemaker, because when we do the myectomy, we take out the left bundle. So if you have a right bundle branch block, most likely you're going to end up with a permanent pacemaker.
Okay.
But otherwise, the overall risk is about 2 to 3%.
2 to 3%. So if somebody's not feeling well after their myectomy, it's probably a good idea to get a Holter monitor if you can't quite get a hold of the symptoms, and make sure that there's no heart block present.
Right. Well, routine EKG will show heart block frequent sometimes, but yeah, maybe you need a monitor sometimes.
Okay, Andy, you're asking a very complicated question, and I'm going to repackage that question to a more general status. If a mother is positive for HCM, but her children have a more significant presentation, massive hypertrophy and a lot of scar, and the child needs an ICD, does that link go up the family tree the same way it goes down the family tree? I'll give another example. If a parent has a cardiac arrest and survives, and the child that is found to have HCM and needs an ICD, that's a clear pathway because you have the first degree relative.
Well, depends on lots of things. How thick was the mother's heart? If she was really thick, then that put her at increased risk. But let's suppose you're gene positive, you don't have a lot of hypertrophy, your risk may not be as high. You sort of have to look at each, it had been always said that if there's a family history of sudden death, that puts everybody at increased risk. And I'm not sure that's entirely true. And so you have to risk stratify everybody. You want to, the classic example I had one family a number of years ago. The one patient I saw, he had very severe hypertrophy, and he didn't want to have surgery. We ended up doing alcohol septal ablation on him. Then I see his nephew, who had a 14 millimeter septum, which isn't very thick, but abnormal papillary muscles and severe symptoms and outflow tract obstruction. And we repaired his mitral valve. And then there was the boy's mother, who was the sister of the first patient. She had no evidence for hypertrophic cardiomyopathy, but all three people, the uncle, the sister, and the boy with a papillary muscle abnormality, no hypertrophy, all were myosin binding protein C3. So the anatomy was all different. And you just sort of look, and one of the other things you have to be aware of is, suppose you see somebody at the age of 15 and they're myosin binding protein C3 positive. You got to continue to watch those echoes. And I have one patient who, when we saw him, he had normal septal hypertrophy at the age of 15, and by the time I saw him 10 years later, age of 25, he had an over 20 millimeter septum. So, most of the patients we see with hypertrophic cardiomyopathy, we're seeing them when they're having trouble. So we get to see their anatomy and see how thick it is and all that stuff. But, we don't know when it started. We don't know exactly when the hypertrophy developed. So, haven't seen many patients with that serial echo that you see it growing from normal to being very thick, because they just don't, they don't show up when they're not having a problem. But that particular person, the 15-year-old, showed up because there was somebody else in the family, and we screened them genetically and saw that it was myosin binding protein C3, and we saw him actually he didn't come back for a few years, and then all of a sudden we see him and he's got severe hypertrophy. So
that reminds me of an older story of a patient who, at the very early ages of doing MRI, had gone, I believe it was to you guys at the Cleveland Clinic, for an early MRI before we were using gadolinium even. And they checked in once with the Center of Excellence, and they were told, yeah, you've got some good old HCM here, you should manage it. And he never went back to a Center of Excellence. He ends up having a cardiac arrest years later. And on the MRI that was done like 7 years afterwards, where now we know to use gadolinium, we're talking like 99, 2000 was the first screening. He had a great degree of scarring. And, you know, there are bad outcomes and there are tragic outcomes. This gentleman did survive his cardiac arrest, but has severe brain damage as a result, and has a very short-term memory loss, or he only remembers things for a couple minutes at a time. So it's really important to recheck back in with new data. What we know today is what we know in April of 2020. We're constantly evolving and we're learning more. And I know everybody wants all of the answers tomorrow, and we're learning right now in real time that diseases do things to the body that take us a long time to understand. We're living through COVID-19. We don't know all of the damage that is being done by this. We don't know what the long-term impact on these lungs are going to be. It's going to take us a long time to figure this out. And it's going to take a long time to figure out the other things that we don't know about HCM yet. We do have a couple questions here about, and this just came up in the Facebook group earlier this week, a left bundle branch block. Some people seem absolutely shocked after their myectomy that now they have a left bundle branch block on their EKG, and they're very upset about it, and they think something went wrong. Could you explain what a left bundle branch block is and why it happens after a myectomy?
Well, the left bundle branch block occurs because in the area of where we're usually doing the myectomy is where the left bundle, that wire that goes through the heart on the left side to conduct the electricity down into the heart and on the left side. So when we cut that left bundle, you get left bundle branch block. So the conduction is now going down into the right ventricle and then coming up backwards from the apex up. So that's what a left bundle branch block is. But almost 100% of people get left bundle branch block from the myectomy. The other thing we haven't talked about is with alcohol septal ablation, on the other hand. Alcohol septal ablation usually causes a right bundle branch block. So if you have an alcohol ablation that didn't work and you get right bundle branch block, and then we've got to do a septal myectomy on you, you're going to get a left bundle branch block, and then you're going to need a permanent pacemaker.
So what does a left bundle branch block on its own do to somebody? Do they feel it? Is it a problem?
Usually not. And most people with left bundle branch blocks don't have a problem. They just, you don't even know you have it.
So the pathway finds an alternative route to provide electricity to the heart.
Right.
So it's just an alternate pathway of electrical function. That's
right. And the problem is most people are born with a right bundle and a left bundle. So if you go into the surgery with a right bundle branch block because you were born that way, and now we've got to do a septal myectomy, we're going to disturb the conduction in your heart, and that's why you're going to need a pacemaker. But if you start out with normal conduction, the risk of it is only 2 to 3% of needing a pacemaker.
Diane, I hope that answered your question. Brian has a question about mavacamten, the drug that's in study right now. Do you have any thoughts on it?
Well, I don't think we have enough data. Some of the early data looks promising, but we need to study more and see what's going to be. We just don't know yet.
Okay, Bill, you're asking a very specific question here, and I'm trying to not get cross the line between individual consult and general information. So I'm going to package this a little differently. So Bill is asking about settings on his ICD after his myectomy. If there's changes in the report regarding R wave oversensing and P wave falling into refractory, what does this really mean for a patient if there's changes in their EKG or their changes in their ICD readings post?
Well, I think it's just a matter of just getting things readjusted and, based on what they see when they check them. I mean, if you go into surgery with an ICD, we turn it off. So we don't, when we're, because the cautery that they have to use to stop bleeding can interfere with the defibrillator. So it's turned off, and then we turn it back on, and it's reset for whatever we think we need to do. And then before you go home, you get it rechecked again, and then probably in 6 weeks again. So it's hard to tell you. It just matters what we see, and we'll fix it when we see it.
Back to COVID world. What about people with HCM who are older, 58, non-symptomatic with HCM, just a septal hypertrophy, no other cardiac disease, hypertension? Are they still considered high risk for COVID?
As best we know, yeah. I mean, but again, we don't. The problem is that there are people getting this disease and they have no symptoms at all, and that's it's just we don't know enough. I mean, we are so in the infancy of this problem. A couple of months, maybe, and the data. And so many people got sick so fast in China. I don't know whether they had enough time to collect all the data. Probably hasn't been published or properly collected. I mean, this is acute. Get in there and get the people off the ventilator. It's that. It's putting a terrible strain on everybody, and it's happening fast. And we unfortunately don't have a lot of data. We're really going by the seat of our pants right now, and we're doing the best we can.
Yeah, I'm actually getting a little concerned about what the demands are going to be on our lung specialists, our pulmonary specialist programs, and our respiratory therapists long term.
Right.
So surviving COVID are, from what I understand, being left with functioning lungs that are depleted by 20 to 40%.
Right.
And that's not going to heal. By
again, some of this we just don't know. I mean, we don't know what the burden is going to be, and that's why we've got to do something to prevent the disease. We've got to come up with a vaccine sooner than later. I mean, this is.
So there's a lot of people working on it, and we wish them Godspeed and all the luck in the world to get there. Okay, we're going to change tracks again, and we're going to talk about generic drugs, your favorite topic. So her local cardiologist will not write a script for name brand metoprolol because he doesn't understand why that's necessary. He said to call Cleveland. She's 10 years post myectomy and 10 hours away from Cleveland. Can you do a telephone consult to get your opinion on that?
Sure, we can do that.
So you can call up, or you can dial into the Cleveland Clinic and ask for a phone consult.
Right.
To solve the problem.
Right, and the problem is that metoprolol succinate is a difficult drug to make, and not all manufacturers know how to make it.
Okay, Cecilia, we're going to address this in a more global session here. So Coumadin clinics are closing down, and they're not able to be staffed, and they don't have the PPE to do basic INRs. What do patients who are warfarin patients who are used to going to a Coumadin clinic once a month to check their INR, what do we do?
Well, that's a problem. I have a problem with a patient right now, and one of the things that we don't do enough of is have you check your Coumadin at home, check your INR at home. It turns out when people have done that there's better control of the INR when people are doing them at home. But you got to be taught how to do it. And it basically, to be honest with you, it's not much different than doing a blood sugar.
It's no different.
And with this particular patient, the company that sells these things insists on teaching you how to use the device and all that. And they don't want to send people out right now. So we were kind of caught with this one guy, and I told him, we made an arrangement that he was going to go to the clinic, be there right first thing in the morning. And he would be the first patient in. Wife was going to sit outside in the car. They weren't even going to park the car. They'd go in, get the blood drawn, stuck, and leave.
But in these cases, the Coumadin clinics are closing. So it would be reasonable to request a home Coumadin monitoring system. And with your insurance company and your doctor, there is a home test.
There is. And I don't know the ins and outs of insurance companies paying for this. I mean, insurance companies nowadays are my enemy, and they're a problem, and they they're hopefully with this situation going on now, they'll wake up the fact that we need to do this. And, we'll just have to, we're taking them one case at a time and trying to do, what we need to do. And again, this is one of those things that we didn't expect this was going to happen. And so we've got to kind of adapt to the whole situation. So there's lots of things like that. And we're, hopefully we'll get that worked out. But I, in general, think it's probably a good idea to measure it, to forget this illness that we got now, but do it at home. It's not that difficult.
Okay, so I'm going to go out on a limb here and say, when push came to shove and there was a logical reason, I have always found my insurance company to listen. It sometimes takes a tremendous amount of patience and a little sense of humor and a lot more patience to be factual and non-emotional with them and make an argument. So in the case of home monitoring for Coumadin, in today's world, it is far more cost effective for them to pay for you to have a device at home than for you to have a stroke and end up in the hospital and have to pay all those bills. Well,
I understand that. And sometimes you wonder, do they understand it? And you just got to explain it to them.
And you have to explain. And if you put in your request and they deny it, that's their go-to. So then you file an appeal. And if you're a member of the HCMA, and there's certain things we can only do for members because it takes a lot of time.
Right.
One appeal letter can take me 2 hours to write.
Right.
Because I have to get all the data, and we work with you, and we try to get this the strongest appeal letter possible. And we're about 95% effective on our appeals.
Right.
So I would ask your doctor for a home monitor. I would file it with your insurance company. If they deny it, I would appeal it. And if they appeal, or if they turn down the appeal, I would go to an outside appeal, which has to be done in an emergent fashion, which is regulated by your state Department of Health. And you can fight it out there, and you normally win when you go that far.
Right.
So I would encourage you to fight.
Right.
Okay, I have a couple more questions, and we're going to wrap up in a few minutes because we've kept Dr. Lever for about an hour now. So I'm going to go through.
Nothing else to do.
Okay. Essential employees during COVID, but have to be laid off and collect unemployment. Is there a way to have leave with pay during these times?
We actually drafted a letter to say that they're at high risk and they should not be penalized for not working.
So this is going to depend.
Just sign something like that.
Yeah. So number one, I'd work with your doctor's office. Number two, there's I posted it on the HCMA Facebook page a couple of days ago, your employee rights under COVID, and it breaks down under what conditions you can be off with pay. But the first round of the COVID Recovery Act, or whatever we're calling it, only covers you for 2 weeks of pay. And then you can go to unemployment, but you may lose benefits if you go to unemployment. And it depends on the size of your employer. So be very, very careful because we don't want you to lose your health insurance. We don't also want you to get COVID. And we want the world to go back to normal. And it's complicated, so please be cautious. Okay, so Ed. Okay. I have extreme panic and anxiety along with HCM. It's to the point where I can't leave the house without very bad palpitations and an extreme heart rate. I've been not able to go back to my cardiologist, and I'm not currently on any medications. Is this going to roll?
How come he's on no medication?
I don't know. Is there anything I can take to calm me down that's safe to slow the heart rate? Ed, yes.
Yeah, I think we ought to get him on a beta blocker.
So
if he wants to call and we'll set up a virtual visit, we can do that. And what he needs to do is get, at least if possible, get an echo that was already been done. Send the CD, can send it overnight, and I can look at it from home. And it'll go to my office, and then I have a way to look at it right from my home and look at the echo. And if he's got an EKG, we can look at it. And we can even order we can even order a monitor if we have to, it's called a Zio patch. We can send out to him and we can check the rhythm. So I think they can call if they want.
So I want to address a more global question that speaks to you, Ed, and that is a lot of patients with HCM have anxiety or panic issues. And some of them have symptoms that are related to HCM that can be confused as panic or anxiety related symptoms. It's really important to understand the difference between the two. An event monitor can help do that. And also keeping a log of when you're feeling these things happen. If there is a trigger, and it could be any trigger, it could just be a fight with somebody or a disagreement, or you saw a spider, that's a situational anxiety issue. Whatever your situational anxiety is, if that's bringing you symptoms, those are things that can be handled in one manner. If these panic feelings come out of nowhere, there's a really good chance that it's your heart that's making you feel anxious. And if we treat the heart, we might also treat the anxiety. We have lots of people who come in with their first diagnosis being panic attacks or anxiety. And when you get them on the right meds for HCM, it goes away or it minimizes.
Now, let me also say one other thing that I've been doing with some patients, and not even before this happened with the virus. There is a device made by it's AliveCor is the company, that you can use a cell phone to record your heart rhythm, or you can use an Apple Watch. The advantage of the AliveCor device is you can record from 30 seconds up to about 3 minutes. And you can do one lead, or you can, the one lead device costs $99. If you get the one, there's a 6 lead one that you can get that costs $150. And I just had one the other day, the patient got, and a couple of leads weren't so good, but the others were all right enough for me to see the patient was in sinus rhythm, and with some artifact in one lead, but not in the others. So if you're having problems at home, within about 48 hours, you can order one of these devices, and it's a little thing that if it's one lead, you just put the electrodes on a table right next to your cell phone, put 2 fingers from each hand on the device, and it'll record the rhythm. If you want to get the 6 lead, you put it on, like, on your thigh right near your knee, and 2 fingers on each electrode, and then the other one fits on the knee, so you get 6 leads, and then it's near your phone, and you record it, and then you can email it, and then we can check the rhythm. You can even email it back to the company if you can't get in touch with your doctor. And it's been very helpful. There are a couple of patients that were very nervous, and we looked at it, and they just had a few premature beats and not enough to worry about, and that reassured them, and they felt better. It does cost a little bit of money, but nowadays it's amazing when I looked at I'm sitting at home, I talked to the patient, and then I actually had another patient who did have an episode of atrial fibrillation. She happened to have one of these devices at home, wasn't feeling well, took her rhythm, and then sent it to me, and she had it was a few days before the phone call, and she had atrial fibrillation, and then we recorded it again, and now she was back in sinus rhythm, and we did a longer term monitor on her. So it was very helpful to see that now she was back in sinus rhythm. So that is particularly now, it's a particularly valuable device, and it's AliveCor. You just go to their website, and I've been telling patients you can actually buy it through Amazon, but I've been telling people to deal with the company, because if you have any technical problems, they'll help you out.
So
I have no stock in the company, by the way. I
have no stock in the company either, but I believe in them incredibly. I just where was I? Was it AHA? Either AHA or Heart Failure Society meeting. I guess it was AHA in Philadelphia in November. The founder of AliveCor wandered by the HCMA booth, and we were actually one of the early adopters, and we helped them with some of the early clinical trials. And maybe some of the people who are watching here got the free versions or the $50 versions when they first came out, and we were helping them beta test it in the real world back in 2013, 14. Well, he comes over to the booth. He goes, "You got to see what I have now." And I sat down with the new device, and I put it on my lap, and he goes, "This doesn't look like you." I'm like, "No, I have a new heart now." So he remembered, but that was kind of cute. So you just inspired me to reach out to him and see if he might want to come on live with us and talk about the technology. and how in this time where people are doing virtual visits, this could come in really handy.
Right.
The technology is fabulous. It's FDA approved even. And all you need to do is put it on your cell phone, and it is absolutely amazing. And you can get a lot of great data. I put the link to the AliveCore website here. We don't get any money from them either. We just believe in the technology, and it's really good at-home technology. Okay, so jumping around here a little bit. You might have seen a dog jump up behind me. Sorry. Anna wants you to know that she requested her Lynette and taken off a Teva, and it's they were able to order it,
Right.
and it'll be here soon. The pharmacist was curious about why I wanted to switch. So I hope you took the opportunity to educate your pharmacist on the problems of generic drugs,
Right.
how to get good ones. You're welcome for addressing anxiety. It is a big issue. You're welcome, Bill. Tracy, you have a tricky question, hon, and I'm going to start wrapping things up here. This is a very specific question. To my transplant friends out there, this is a very, very difficult time for us all. Those post-transplant can't get to our centers for checkups and evaluations. And those of you who are listed may find yourself waiting a little bit longer because we're in a very tricky time. And some transplant centers are only transplanting 1s, 2s, and 3s. 4s are not getting called right now. You're just kind of in waiting mode. Some of the programs are just kind of on halt because they don't know well enough right now if you're going to be getting a COVID positive heart and what that might do to you when they bring down your immune system. So out of an abundance of caution, they're waiting until technology catches up so they can do tighter checks and see if the donor had COVID. It's really a complicated time, not to mention that ventilators are at a premium right now, and you're going to need to be on a vent for a couple of days post-transplant. And the fact that the procurement teams are just probably not available right now because everybody's on the COVID front line. So there's going to be some challenges in transplant over the next couple of months. I'm waiting for some guidance from UNOS. I'll update the community as I get that data, but I'm sorry, this is just a really horrible time to be listed. And stay home, stay safe, stay in your little bubble, and hopefully someday soon this will be over. Oh, Terry, you got a long one here. Beta blockers and anxiety. Let me just double back here with you for a minute, Harry. I have noticed anecdotally over 20 some odd years in 12,000 families that I think patients with HCM do not process adrenaline properly, and thereby they feel palpitations and they feel that anxiety, and it's the cat chasing its tail. They get anxious because they feel their heartbeat. They dump more adrenaline. They get more anxious, and it just keeps circulating. Is there something we're missing?
I don't know. It may be, and we do like to keep the heart rate slow and allow the heart to fill, and I think it works better when you do that. And most of my patients are on a beta blocker. The one thing I have to say though about drug therapy, we have a shortage right now of verapamil. I don't know if people know that, but there's only one manufacturer making it, and it's coming from India, Glenmark. And it's been very difficult, and so I've used lately. Actually, even before that happened, I've been using more diltiazem than I have been verapamil, and there are a number of manufacturers for that one. And that's what I've been doing. If I for whatever reason they have asthma or whatever, we can't use beta blockers.
So, Tara, you're also taking some Xanax and Boost Bar for anxiety. These meds can be used, but you do have to watch out because some of them can be addictive, and you want to be cautious there. You've been prescribed a beta blocker. Sometimes a beta blocker works to help with the anxiety as well. So balance that off together, work with your physicians. Please also be aware that you can do two things at once and actually get a lot of progress out of it. Work with a therapist to help manage your anxiety. Work with your cardiologist to help manage your heart. If you're managing your heart and your emotions together, you might find you get a lot more bang for your buck. And the other thing I want to do, because a couple calls came in the past week on this, and nobody wants to be talk to about this during a crisis, but smoking and HCM are a really bad combination. Nicotine brings up your heart rate and it makes your heart beat harder. And you're going to take medication to lower your heart rate and make your heart not beat as hard. And when you smoke and you take these medications, you're not doing yourself any favors.
And you don't want to be smoking and getting this disease either.
So let this be the inspiration to put the cigarettes down once and for all, everybody. Okay, I'm going to Ola, you're going to be the last question here, and we're going to wrap up. Karen, do we need to change our clothes and shower if we visit the grocery store and do the hands and mask and everything else? Number one, masks everywhere. I've been saying this since the beginning, and the CDC was arguing with me, and now they find out that we were right. Masks. This can be airborne. It obviously works in droplets, but it can be.
Well, they're actually saying some of it's aerosolized. But that I don't know how they're doing those studies, but they've said that too, and that makes it even riskier.
So mask in public, gloves in public, come home, go immediately to this is the way we're doing it in my house. Bring an extra towel into the bathroom, put the towel on the ground, take the clothes off, put them in the towel, wrap up the towel, leave the towel sitting there, take a shower. The outside of the towel is clean. After your shower, in this case, your husband, because I ain't touching his stuff, takes it directly to the laundry, and we do lots and lots of laundry now. There's lots of laundry happening here. So wash the clothes, wash your hands, take a shower. Your hair can have aerosol contaminant in it. Wash your hair. So ladies, tie your hair up, do the babushka, whatever you got to do. You got to stay clean. You got to stay away from all the contaminants. Agreed, Harry, my germophobic friend?
No, I think you got to be careful. I mean, we don't know enough about this, and it made no sense when they were saying, oh, you don't need a mask, and you see all these people in China wearing masks, and you just do it, I mean,
yeah. And you don't need an N95 mask.
No.
You just need the particles to not go in. So if you were to put a bandana and you covered the bridge of your nose and you tied it around here and you let the bandana hang to underneath your chin, you're going to cover the face. When you take off the bandana, take it off from the back to the front and immediately into the wash. Don't wrap it up in your hands. Just one hand, boom, and into the laundry.
And the other thing is when you're taking the gloves off, you take it and you pull it from the bottom and inside out on the one hand, and then sort of the same way on the other hand. You don't touch the outside.
Never touch the outside.
Or the way surgeons take them off when they're in the operating room.
Yeah, go watch some good doctor shows. They do that kind of stuff really well because it doesn't require a lot of skill to learn how to take on and off the gloves, and they look very official while doing it. That part they get right on most doctor shows. Okay. Couple last comments. Clinical trials are not necessarily on hold, but they're not enrolling any new patients right now in any of the HCM trials. We're just waiting for a little while to bring them on. If you're in a clinical trial, follow up with your clinical trial coordinator and they'll let you know how to proceed. And we thank all of our trial participants and stick with it as best you can. And if they tell you for safety reasons they have to take you off the trial, that's just the way it has to be right now. Thank you for your participation. Somebody else asked if there was a registry being formed of COVID and HCM. Right now, they're trying to save people's lives with COVID. To be able to do a data analysis of who has underlying conditions of what, it will eventually come out. But don't hold your breath for any late breaking news on HCM COVID. This is the treatment pathway. It's not going to happen.
No.
It's not. There's not enough people with it, and there's too many other pressing issues. We have to get these people through their COVID crisis. We have to get them, off of ventilators. We have to get them recovered. And then when we do data analysis later, I'm sure we'll see all of that. Okay. Harry, thank you so much for all of your time today. This is really helpful. If anybody else has any additional questions, we'll probably be doing more of these sessions with the different physicians over the next couple of weeks. Just keep the questions coming. Stay involved at the Facebook page. Remember to like the Facebook page. I'd like to see us hit 12,000 very soon. So pass it along to all your friends and family. And I will also tell you now, this is little breaking news. We're going to be taking all of these sessions and we're going to be putting them into a different format, which is something we were just starting before all this broke, and that is our podcast called Tales from the Heart by the HCMA. So we're going to take the audio from all of these sessions and we're going to create podcasts out of them so that you can listen to them while you're taking your nice long walks out on a nice spring day, because that's about the only thing you're going to be doing outside the house these days. So you can watch the podcast or listen to us here, watch it as a podcast. So give us a couple of weeks, but we'll get them all up in the podcast platform. All right, guys. Thank you so much for joining us and have a great day. Stay well. Stay in.